Hi, I'm Dr. Tom Field, and in this video, we're going to introduce mental health diagnosis. Let's talk first about the relevance of diagnosis. Gaining skills in diagnosis and treatment planning will help you to prepare for your comprehensive exam when eventually you take that, prepare for the licensure exam for counselors in the United States, the clinical licensure exam, I should say, the National Clinical Mental Health Counseling exam, to know the common language of insurance companies and other practitioners. And often your colleagues will expect you to use mental status exam terminology as well as diagnostic terminology during discussions. Know when to refer to specialists such as psychiatrists, nurse practitioners, because, for example, there are going to be times when you do need to make that referral, and understanding what you're looking for, what kind of markers there are of more significant problems can be helpful. We can actually use a midwife metaphor to explain this a little bit. I think counselors are like mental health midwives in a way, in that midwives have this responsibility to really facilitate a natural birthing process. They help support a person in their own journey, if you will, and they don't intervene when not needed, right? Their goal is just to really facilitate and support what the person's already doing. And I think counselors act similarly. They do not have a role as a surgeon, meaning they do not engage in, we would call this uh, 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 invasive procedures in order to help people. Okay, and in fact, when that occurs, when a person is in the labor process, and the midwife determines, actually, this person is going to need a more significant medical intervention to help them, they would then contact, right, the surgeon. They would have the person go to the emergency room. And so the same kind of thing happens to the counselors. There will be times where you're dealing with something that is more significant or severe than you can handle alone, and you would reach out to medical providers. And to do that, if you're talking with a surgeon, say, you're going to need to use medical terminology if you're a midwife, and the same thing if you're a mental health counselor with a psychiatrist or a nurse practitioner. As we go through this course, I want you to be using person-first language. What is person-first language? It refers to basically thinking about people as holistic, as more than just their diagnostic label. And so instead of using a pejorative term such as schizophrenic, referring to a client as a schizophrenic, we would say a person with schizophrenia, because their diagnosis is only one part of their experience, right? Or their symptoms are one part of their experience. You will have a certain experience learning diagnosis as you go. And I wanted to kind of highlight for you some of the things that you may be going through and experiencing in this course. The first is self-diagnosis, right? That as you read through the DSM-5, you're going to think, oh, do I meet the criteria for that? Or does a family member meet the criteria for that? And what I encourage you to do is to try your best to avoid doing that, because it isn't really helpful. And what I think you also have to do is give yourself some grace that you're going to think that way at times, right? But that's, unless you really do think you meet the criteria for something and need help with it, it's not really that useful. You will also have certain feelings come up about the act of diagnosing people. For example, if you identify as someone who likes constructivism, this idea of multiple realities coexisting, it's quite difficult then to look at someone else and say, well, you definitely have this diagnosis, even if the other person doesn't see it that way, right? Or if they don't think they have a problem themselves. And so there's this feeling of judgmentalism, right? Like, who am I to judge whether or not you have a significant problem? That can be, I think, one of the things counselors often struggle with, as well as humanism and the use of labels. As I mentioned before, if we're not careful, we reduce a person to their label and ignore the rest of their lived experience. And so I want you to hold those things as a counselor. I don't want you to drop them. I think the act of being a counselor is holding multiple things at once, right? That the humanistic part of you, the constructivist part of you is important as a counselor, and yet you have to diagnose people. And so you have to sit in that conflict a little bit, okay? And that's important because there will be times where it fits for you to make a diagnosis for a client, and other occasions where it doesn't fit perfectly, right? And you have to figure out a strategy, maybe with consultation, sometimes even including the client in it, to figure out what best fits when you don't think the client meets the criteria for a diagnosis. Also know that as you go through this course, some topics will be triggering to you, right? There are going to be things that just bring up things for you. And if that occurs, I would suggest taking a break and coming back to the material after you've had some time to reflect on it. It doesn't have to be like a long break. Certainly an hour or two isn't a bad idea, maybe even a day if you need it. And to reflect on why this topic has brought up stuff for you, right? And maybe to do some journaling around that, or if you have a therapist already or a counselor, to go and talk to them about that. It's important that you identify a plan to work on any of these topics that are challenging, because you will have to sit with clients who experience these things, right? And who bring these into counseling sessions. So give yourself some grace again, know that it may be a challenge and something to work through. Okay, let's talk about the act of diagnosing and how challenging it can be, okay? Diagnosis in mental health is different than diagnosis in other medical professions. We in mental health have a lack of biomarkers. What I mean by that is, if you go into, let's say, a primary care physician and you think you might have something like high blood pressure or a cholesterol problem or diabetes, there is a very clear test that you can give for each of those things to determine whether or not, yes, indeed, you have high blood pressure, cholesterol, diabetes, okay? But you go into a counselor or frankly, even a primary care doctor and say, I think I may have depression. There's no blood test for that, at least not at this time, right? There's no clear test that will say, yes, indeed, you have depression. Instead, we rely on client self-report, right? We have these symptom checklists, which is really what makes up the DSM-5. What that means, though, is that things are not always clear. And so you could have two different providers who may perceive the same client presentation differently. They may allocate a slightly different diagnosis because there's no one clear-cut diagnosis based on testing, right? Lab testing, etc. And so it creates categorization challenges and just things to be aware of as a counselor that will make your work, just a little bit more, let's call it nuanced gray area, okay? The first is cross-cutting symptoms. So with categorization, we assume that a client meets all of the symptoms within a certain classification, a certain category. For example, all of the symptoms of major depression that are needed for that diagnosis. Ideally, that's the case. What often happens, though, is that you'll have a client who has cross-cutting symptoms. They may have, for example, a symptom like fatigue, and that could be a symptom of generalized anxiety. It's actually a symptom of GAD, or it could be a symptom of major depression. And so it's not real clear as to what the diagnosis is, particularly if, to our next bullet, they have sub-threshold symptoms, meaning they don't meet full criteria for either major depression or generalized anxiety. In that case, it becomes complicated to make a diagnosis. Another complication is that it is kind of true, kind of not true, that some symptoms have more prominence than others. Now, no one symptom has total prominence, that you just need one symptom and then you meet the criteria for the disorder. Usually that you have to meet a certain number of symptoms on the list, say 5 of 9 for major depression as an example. But it is also true that there are some symptoms that are more important than others. And an example that would be with schizophrenia. We are definitely looking at the positive symptoms. You need to have hallucinations or delusions really to meet the criteria for that disorder, in addition to the negative symptoms. Okay. So there are some symptoms that are more important than others, but no one symptom alone is the criteria for a disorder. And so you do have to, even if a person has a really severe single symptom, you have to look at the other symptoms within the cluster. Another challenge for categorization is that you will see within a singular category, singular disorder category, say, great example, this would actually be generalized anxiety. There are a lot of different ways that can manifest when you're working with clients. Same with major depression. So for example, with anxiety, you can have clients who experience more physiological anxiety, the heart racing, the sweatiness, sweaty palms. Other clients, it's more cognitive, like they worry a lot, but they don't have the physiological aspects of anxiety. And other clients who have more of the, say, the fatigue and difficulty concentrating, the attentional aspects of anxiety, okay? And so which of those is generalized anxiety? Well, they all are. So that can make, again, the diagnosis complicated, because even within that categorical structure, you have different manifestations of anxiety. And as I mentioned before, that can result in inconsistencies and potentially incorrect interventions if you're not careful, right? Because you can misdiagnose someone and then refer them to, for example, a psychiatrist who could prescribe a medication that's not warranted, or you may engage in a counseling treatment that just isn't the best. Maybe it's not harmful, but it could have been a better choice if you'd have correctly identified the diagnosis. So it creates a challenge when you're working in mental health, and you do have to be thoughtful about these symptoms and try your best to carefully assess for them during intake sessions. The other major complicating factor that we'll talk about now in a forthcoming slide is the concept of normality. None of us love that term, normality and abnormality, because that concept is all about what is outside of the norm, what is outside of social expectations. And what I will say to you is that while mental health diagnoses absolutely do exist, meaning that a person who experiences depression or schizophrenia, that those things aren't made up. They're not social constructs. They're real for people. However, the way that we understand them is definitely through that lens of social, cultural, environmental. So for example, the way that we understand anxiety, there are cultural syndromes, manifestations of anxiety, things like, and I don't speak Spanish, so I'll butcher this, ataque de nervios, the attack of the nerves. That's a different understanding of anxiety in certain cultures than one would say a panic attack in Western society. So the way that we understand these issues and abnormality and normality is influenced by culture and cultural heritage. It's also influenced by cultural norms and expectations. So for example, a person who is a person of color and they present in counseling with some symptoms of, let's call them paranoia, like worried that the police are after them, that may not be unwarranted, right? That may not actually be a diagnosable symptom. It may just be reality for them. And so that's another thing to kind of know, that our concept of normality and abnormality is going to shift a bit depending on the circumstances we're in, the environment we're in, the time, the age, the epoch in which we live. I'm going to give you an example of this that will hit home a little bit, okay? I want you to imagine that you're working with a client who presents in your office with the following symptoms: anxiety when leaving home for any social engagements, mistrust in others, frequent worries about the health of family members, frequent use of medical tests to rule out a medical problem, and time-consuming attendance to personal hygiene and hand washing. Okay, so just imagine you have a person presenting that way. Okay, think about what diagnosis would this fit? Now, if you're anything like me, you look at this presenting list and you think, actually, I know a couple of diagnoses that could fit this, right? But here's the thing that's interesting, right? In the age of COVID-19 and the pandemic that we're currently in at the time of this recording, all of these symptoms are things we're all going through to an extent. We all feel, to most of us, feel anxious when leaving home for social engagements, right? At least I did when I first started hanging out with people after being quarantined for so long. We may feel mistrust in others, right? Are people wearing their masks correctly? Have you been around an extended bubble of people and gotten exposed? Are my family members okay? Are they vaccinated? Are they taking care of themselves? You may be using medical tests to make sure you don't have a COVID-19 infection, particularly if you've been, say, exposed recently. And then, all of us engage in very frequent hand washing and carry around hand sanitizer, right? Most of us do that. So these things outside of a pandemic, yeah, they're pretty dysfunctional, right? They take up a lot of time and energy and emotional space and make us quite anxious. During a pandemic, they're normal. So it's worth just taking this in for a minute, that the way in which we understand mental health is very much influenced by our social environment. Okay, let's talk about the DSM-5 and some of the limitations of it. You should know that the DSM is an imperfect tool developed by humans to attempt to define constructs that really exist. Like I mentioned, depression, schizophrenia, they're real for people. People who experience them, it's not made up, they're not a social construct, it's real for people. And the way in which we have classified them and tried to describe them in the medical field is a human construct, right? It's our best attempt at trying to classify these things, and it's not perfect. And that's why they revise the DSM every so many years, right? To better try to capture things. So know that you're working with an imperfect tool. I think if you understand the DSM as that, it feels a bit more comfortable to use it versus seeing it as some kind of authority, that can be problematic because it is imperfect. So what we want to therefore avoid, based on this knowledge of it being imperfect, is applying the medical model without concern for environment. We don't want to, for example, look at a client and say, well, you have this diagnosis, and not consider, for example, things like, well, maybe this paranoia is because of recent police brutality, right? And the person is more anxious than would be potentially expected, for people from a dominant culture. If we're not careful, we think too much from a position of internal reference of control, right? That the person themselves is responsible for their symptoms, and it's not the environment, and that can be unfair to clients, right? Can miss some of the issues going on because maybe the problem is the environment itself, and you need advocacy to address it. As I mentioned before, we don't want to be reductionist, just consider people as their label. The way to think about this from a two-person psychology model is we don't want to distance ourselves from other people, right? You have schizophrenia, you're different than me, right? You're not someone I can relate to. I think that's very dangerous for counselors to think that way. Instead, we're all human. Sure, you may not experience the diagnoses that other people, the symptoms they experience, but that doesn't mean that you're so different from them. You will also work in your career, especially if you work in outpatient and even more than that, private practice outpatient settings, with clients and students who come to you and their concerns aren't really diagnostic, right? They're more developmental, they're more humanistic. They're things like, I'm experiencing this existential crisis over my identity. Maybe it's my gender identity, or maybe it's the current job that I'm in that I don't love. It's not really a great fit for who I am. Are those clients diagnosable? Not really, right? I mean, they're not, unless they're experiencing diagnostically relevant, significant anxiety and depression, then really they don't have a diagnostic problem, but you often will work with clients who they don't fit a criteria perfectly. And so that's another limitation of the DSM-5. It's really developed for diagnosing significant mental disorders. And not every client you'll work with has a significant mental disorder. To kind of know that and know that sometimes it's not appropriate to make a diagnosis. And if the client absolutely needs to use health insurance and therefore you must make a diagnosis. Don't know if you're familiar with this, but you have to make a diagnosis by the end of the first session for insurance companies. So when that occurs, you have to talk with the client about it, right? And I wouldn't typically diagnose you, but we're using health insurance for this. And so we need to consider a diagnosis that is pretty mild, such as an adjustment disorder, which we'll talk about in a subsequent week. You should also know about the DSM-5, that it doesn't have a flawless history, we'll put it that way, like that it can be used as a tool of oppression if we're not careful, and some of the way that it has captured experience in the past has been oppressive. And I'll give you one example. It was only after 1980, 1980, that homosexuality, being gay, lesbian, bisexual, was not considered a mental health diagnosis. Up until DSM-3R, I believe, up until then, the new edition, which came out in 1980, it was a diagnosis. Homophobia was a diagnosis. Sorry, not should be homophobia, but homosexuality was a diagnosis. And psychological testing, such as the MMPI, even had a criteria for homosexuality as a diagnosis. So obviously that's oppressive, right, to people, very offensive to people who are gay, lesbian, bisexual. And so what's happened obviously since then is that's been removed, but we still have some remnants of that line of thinking in DSM-5. You'll notice one of the, for example, diagnoses is gender dysphoria, which many of us feel is inappropriate and will probably be removed in a subsequent version of the DSM. So just kind of know that the DSM-5 is not necessarily a progressive manual, and it does sometimes have diagnoses that are inappropriate in there. Okay, I'm also going to talk about another, it's unfair to call this a limitation of DSM-5, but maybe a movement away from a DSM type of nosology. What nosology means is a categorization system. So we're moving really more towards an integrated model of understanding people using science. And the National Institute of Mental Health, NIMH, created in the 2010s, I believe it was, the research domain criteria, what they call RDOC, which is a new assessment paradigm. And I think it's going to be used not right now, but in the future, as of when technology becomes more accessible for people. The idea of RDOC in this graphic you can see is that you take a construct, for example, anxiety, and the assessment of anxiety isn't just going to be based on self-report, which you see in one of the bubbles around the construct, and not just behavior either, a person's observable behavior in a session, but also their physiology and things like circuits and networks, cells, molecules, and genes. We may be interested, for example, about cortisol, the person's amount of cortisol in their system. We may be interested in, do they have any neural decline, which sometimes you can see in people who have experienced anxiety? Do they have a problem with GABA, or gamma aminobutyric acid as it's known, that it's too low? Those are things that we don't have access to right now. We don't have easy ways of testing that. But in the future, we hopefully will, and it's going to lead to more accurate assessment. Gets really back towards the biomarker argument that eventually we may have more accurate ways of diagnosing people, okay? Here's an example using fear. So with fear, you may use something like a self-report inventory, like the trait fear inventory. You see that in one of the bubbles. You may assess behavior such as freezing behavior, fight, flight, freeze. You're probably familiar with that. But then you'd also be looking at things like a person's heart rate, which can be a proxy for sympathetic activation. In other words, the adrenaline is flowing through the system and that person's heart rate increases. We may be interested in the activation of the hypothalamus, which sends a message to the pituitary gland and the adrenal cortex to release cortisol and adrenaline, the HPA axis as it's known. We may be interested in neurons, right, and the functioning of them, as I mentioned, and decline of them, cortisol, and then brain-derived neurotrophic factor, which is a growth hormone involved in the growth of new neurons. So this isn't coming now, this is like the future, but it is worth noting at least now that when you're being trained in diagnosis, it really would behoove you to learn some basic neuroscience and to start learning how mental disorders are best understood from a brain-based perspective. And so in this course, I'm going to train you in the biopsychosocial model, and I will be bringing in neuroscience just so you have that background and understanding. Okay. So we use the DSM-5 as counselors with acknowledgement of all the following. First, the diagnostic process is shifting towards an RDOC model, and also as an extension of that, more individualized assessment, what we call idiographic rather than nomothetic assessment. What I mean by this is, does it really matter if a person only meets 4 of 9 symptoms of major depression and doesn't meet the criteria for it? Not really, if their symptoms are really significant to them. What's more important is that we're tracking those specific symptoms, seeing if they get better or worse over time. Maybe there's one of those symptoms particularly the client's most bothered by, could be depressed mood or sleep trouble, and we really focus treatment on that, and then we're tracking that over time. That's individualized assessment rather than just looking at a person and whether they or not they meet categories, right? Because think about it this way, if you use the DSM-5 and if you look at major depression in there, let's say a person does meet 5 of 9 symptoms and over time their depression lessens, it's still very hard to know, okay, what does it mean to go from moderate to mild depression? Or what does it mean if certain symptoms get better and others don't? It's not that individualized, right? A categorical system is not that useful clinically, particularly. You should also know that sometimes a diagnosis is not indicated. We've talked about that before. Going back up to the previous point too, just to emphasize this. You'll notice when we talk about cases, we talk about diagnoses, that I want you to really be focusing in on what are the symptoms, not just what is the diagnosis, because it's tracking those symptoms and addressing those symptoms that is often a key part of treatment, okay, because from an individualized perspective. Diagnosis should be a collaborative process with a client as well, especially in cases where the, whether or not you make a diagnosis is up in the air. And also when the client may be sensitive to the diagnosis, meaning a client may, for example, not want to be diagnosed with something like depression. And you should be talking with the client about, where you're leaning and why. And I think giving client autonomy during that process matters, some degree of say. Diagnosis should also be determined based on, this kind of moves from our next point, based on likely consequences. For example, are you making a diagnosis because of resources, meaning The client needs to access insurance benefits, and so you need to diagnosis for that. Or is the diagnosis useful when the client needs a more, we'll call it a more acute level of care? Let's say that they're in outpatient, it's not helping them, they need a day program. Well, the type of diagnosis they have will matter. And so making an accurate diagnosis, you don't want to overdo it. You don't want to upcode what's called a diagnosis, make it more severe than is actually indicated. But you do want to assign a diagnosis that's accurate if it's going to give them the services they want, right? So we should think about the consequences on the positive end and also on the negative end of things, which is, if we're not careful, there are ways in which a diagnosis can negatively impact a person, and we should be thoughtful about it from that perspective. Here are two very quick examples. If a person wants to enter into the military, sometimes a history of a mental health diagnosis can actually limit them from pursuing different activities, tasks within the military. For example, it can affect clearance. The other thing you should be aware of is that there are diagnoses such as bipolar disorder that if a person has a diagnosis of one hypomanic episode, only one in their lifetime, they will forever have a diagnosis of bipolar disorder, even if every other episode is a depressed one. So not to say you shouldn't make that diagnosis, but you should make it with caution, right? Because that diagnosis will follow them for the rest of their life. Okay, now that we've introduced the diagnostic process, we're going to look at how you would engage it, right? How you would make a diagnosis using DSM-5. You should know that the DSM-5 boils down psychopathology to 4 criteria: symptoms, functioning, distress, and severity. Symptoms, as you might imagine, does the person have depressed mood, or do they have difficulty concentrating, etc. Okay. Functioning, is the person able to perform the tasks of daily life? Are they able to go to their job? Are they able to study? Are they able to do things like have meaningful relationships with other people? Okay. Distress, is the person upset about the symptoms that they experience? A symptom like depression, like depressed mood, can be very unpleasant. No one likes experiencing depression, right? It's a very unpleasant experience, and it causes distress to experience it. People don't like it. They want it gone. They want it to stop. And so distress is another marker of psychopathology. And then severity, how severe the symptoms are, whether they are mild, moderate, or severe. Typically, we measure severity by frequency, how often it occurs, duration, how long it occurs, and intensity, how severe it is. Okay. I will note that for most mental disorders, functioning and distress, 2 and 3 of those 4 bullets, are very important to a mental health diagnosis. I'll also mention here that the time length often matters as well, that a client often has to meet a certain time length in order to qualify for diagnosis. Okay. A person must meet minimum threshold, as I mentioned before, for major depression. It's 5 of 9 symptoms. 4 of 9 is subthreshold, does not meet the criteria, you cannot diagnose it. No single symptom is the sole criteria, as I've mentioned, for a disorder. And some symptoms are more significant than others, but no one symptom is enough for a mental disorder. And that's important because all of us could experience different symptoms at varying points, right? Let me just kind of pause on this for a second. You could experience depressed mood for a couple of days. I have. You could experience chronic worry for a couple of days. I have. You could experience difficulty concentrating for a couple of days. I have. None of those things in isolation means you have a mental disorder per se. Now, other things such as experiencing psychosis would be more concerning, right? And so some are more important, right, to attend to, but no one single symptom is a criteria for a mental disorder. When making a diagnosis, you want to be thinking about 3 ways of coding, okay? The first is principal diagnosis or reason for visit. The second is provisional. The third is rule out. So what is each? A provisional diagnosis or reason for visit is basically the reason why the client is coming in to see you, okay? It's the most important diagnosis, and treatment planning should directly address this. Now, it's not necessarily what the client says is the reason they're coming in. You still have to make an assessment. The client could say they're coming in because they're anxious, but really the presenting issue is their substance use. That's the major reason that they are seeking therapy, because it's causing issues in their personal life, which is then causing anxiety, okay? So you still make your assessment, But the thing you mark first, I guess, is the thing to emphasize here on the diagnostic sheet, if you're going to make a diagnosis, is the thing that you're addressing first in treatment. Okay? We'll talk about treatment planning later to explain why this matters. Usually, by the way, personality disorders and intellectual disability are not listed as clinical disorders and thus cannot be the principal diagnosis. The reason for this is, and it goes back, it's historical, goes back to previous editions of the DSM. The DSM-4, for example, had a what's called multi-axial system, whereby personality disorders and intellectual disability were on a separate axis than the clinical disorders. This decision was made because the gurus of the DSM have determined that those two issues are stable and chronic, meaning they're not treatable fully. Now, many of us would argue that personality disorders actually, you can make some pretty significant change there, though it takes a long amount of time. Maybe you don't change the fundamentals about what the personality disorder, but the coping with the symptoms of it can improve a lot. However, if you submit a personality disorder as the first diagnosis to an insurance company, by and large, they will not cover it. So just kind of be aware of that. Then we have provisional and rule out. Provisional is very useful because of the advent of you having to make an initial diagnosis in the first session of working with a client, and often feeling like you don't have sufficient information, right? That you're missing information, or what often happens is you believe the client would meet the criteria if you either had more information or if the time length elapsed a little longer. And so in those cases, you would use in parentheses provisional after the diagnosis. Okay. Another possibility here, other than provisional, by the way, is just using a less severe diagnosis. So instead of, for example, major depression, or which is clinical depression, major depressive disorder, as the diagnosis, you could list unspecified depression, which is almost like the sub-threshold version of depression, and then rule out major depressive disorder. What is a rule out? A rule out is when you don't have sufficient information and you need more information to rule it out to make sure it's not that. Okay, so you'd only use provisional if you believed that the client truly was going to meet the criteria, but they just hadn't had enough time yet, or need more information, but you're pretty sure it's going to be that diagnosis. If you're not sure, then I think the safer option is to give an unspecified or a lesser type of diagnosis and to rule out. So another example of a lesser would be an adjustment disorder with depressed mood, which is also a less severe version of major depression. Okay? And you can have several rule outs on your diagnostic sheet, sometimes 3-4 rule outs, right? These are all of the diagnoses that you are considering. They're differential, meaning you're not sure which of these really fits, but you would need to rule them out to be absolutely sure that the client indeed had that diagnosis that you're settling with. It's worth noting here that one of the first things to do during the diagnostic process is to rule out organic cause. Rule out organic cause. What do we mean by this? Medical conditions and substance use should be ruled out first in the process. Reason for that is that a client's symptoms could just be attributed to their medical condition or substance use. Here is a quick example. If a client has low thyroid hormone, if they have what's called hypothyroidism, okay, then they may present with symptoms of depression, but it's not depression, it's just low thyroid hormone. And what will happen is if you don't assess for this, that if that isn't caught, if you will, and they go through counseling, they may not make progress, right? Because it's a medical problem. It's not a mental health problem per se. So just kind of know that it is worth ruling out these things first. Same with substance use. Substance use can mask a lot of mental health symptoms. So this has implications for intake interviewing. You should be asking about history of medical symptoms, as well as recent physical exams with labs. If they haven't had that done recently, it's always a good idea to do that within a couple of weeks of the intake session. And in addition to that, to really emphasize substance use during the intake, make sure you ask a question about it. It often is forgotten, but it is an important question. And I can't tell you the number of times during initial phone call consults with clients that I haven't asked that, but during the initial session when I meet with them, the client says, the reason I'm actually seeing you is because I have a really significant alcohol problem, etc. So it absolutely should be asked about. Okay, there are other complications with co-occurrence as well, just to be aware of. The first is that there are actual diagnoses in the DSM-5 in which a medical condition or a substance use condition has induced a mental health symptom. Let me quickly give you some examples. A medical induced condition would be something like a person has, let's say, a major surgery. It could be something like brain surgery, and they have a mental health symptom subsequent to that. It's medically induced, meaning it would not have occurred without the medical condition, right? But it's really just caused by medical, meaning if you address the medical, it will eventually go away, okay? Actually, that's not true. Sometimes it doesn't go away and it's just induced by that. And that makes it important for the diagnostic picture. So for example, you can have people with surgeries where their mental health symptoms don't go away. And that's also still would forever be coded as, let's say, medically induced depression, for example. Substance induced, same thing. You can, perhaps the most famous example of this is a person who uses cannabis or marijuana and develops psychosis secondary to that, and therefore has substance-induced psychosis. Their psychosis may last the rest of their lifetime, and so it would always be coded as substance-induced psychosis from that, okay? The reason I wrote here note inpatient is that often this happens in inpatient units, that you know, a person will have these conditions subsequent to medical or substance use. In addition to that, you can also have a person with mental health symptoms that are genuine, that are in response to a medical condition, okay, that are not induced by it per se, but are in response to. Let me explain what I mean. I have once worked with a client who had muscular dystrophy. I've actually worked with a couple of clients with muscular dystrophy. One of them had really significant anxiety about their own decline, physical decline, because of worries that they would get, you know, worse over time. They would be in a wheelchair, and they had a lot of anxiety about it. The anxiety, the mental health symptom, was caused in relationship to the muscular dystrophy. Okay, so it was caused by it, but it would not be medically induced per se. It would be a separate diagnosis. Okay, so what I mean by this is that you would instead code muscular dystrophy, as well as, assuming it's been assessed by a physician, you really can't assess for that, not qualified to, and would also have a diagnosis of anxiety, right? That's separate. It's not a medically induced anxiety, it's a separate diagnosis, okay? And then, of course, substance use can cause mental health symptoms, alcohol being a notable example, that a person can have an alcohol use disorder and then a secondary diagnosis of depression that is in relationship to alcohol, but it's not induced. It's just, it goes along with the alcohol use. For example, they may be using alcohol because they're depressed, right? So I'll note here that this is a complicated subject, a complicated slide. Just to summarize, there are 3 ways in which co-occurrence can occur, 3 ways. The first is that it's not a mental health symptom really at all. It's just a medical or a substance use condition, okay? And that would be the case of something like hypothyroidism. The second is it's medically induced or substance induced. An example, this would be post-surgery, problems like amnesia, or it could be substance-induced psychosis. And then the third type is when you have a genuine medical condition and then a genuine mental health condition that is not induced, but it's in response to, in relationship to, and so it's coded as a second diagnosis. Okay. So in the first case, you would not make a mental health diagnosis. In the second case, you would make a medically induced or substance induced diagnosis, which is a separate code in the DSM. And you'll see this when you read through the chapters. And then the third situation, you would code 2 things, the medical condition or the substance use and the mental health symptom. So here's an example DSM-5 coding using alphanumeric codes. Major depressive disorder, single episode, moderate, provisional, reason for visit. Provisional meaning you don't have quite enough information yet, but you're pretty sure it's that. It's the reason they're coming in. The code is F321. Then you have post-traumatic stress disorder with dissociative symptoms, F4310. It's secondary, meaning it's not the reason they're coming in, but it's there in the background. It may need to be addressed eventually. Okay. And then you have rule out F515, nightmare disorder with associated non-sleep disorder, persistent moderate, that there are potential sleep problems here, nightmares that may not necessarily be attributed to PTSD, may be separate, that needs to be ruled out. In clinical coding, this would read as F321, F4310, and rule out F51.5, meaning you wouldn't write all of the text, you would just write the code. Okay. I'll note here that when you read through DSM-5, there are actually two codes by each diagnosis. There is just a pure numeric code, and then there is the alphanumeric code. You are going to be using the alphanumeric code. The reason for that is, very briefly, that you are using ICD-10 codes rather than ICD-9 codes now. They changed the version of ICD, and the DSM was kind of written to reflect this. What's interesting about the DSM is that all the codes in the DSM are not written by the DSM workgroup. They are ICD codes. ICD stands for International Classification of Disease. The group who developed ICD was the WHO, World Health Organization. And so what DSM is as a manual is they take all those codes and then they write the criteria for those codes. So for example, the code for major depression, F32, that was a code that was created by ICD, but the description of that, 5 of the 9 symptoms, for example, that was created by DSM. Okay, next is a very important point, being in the ballpark. You should know that diagnosis is not an exact science, as I mentioned before. And so what I'm looking for as you work through the case examples, the vignettes in this course, as we talk about diagnosis, I'm looking for you to be within the ballpark, meaning as long as you are looking very closely at the symptoms and finding a diagnosis that matches the symptom profile, I'm okay with a bit of variation within that. An example would be, let's say you have a client who presents with some minor depressive symptoms. They don't have major depression. They have minor depressive symptoms, okay? I would be okay with adjustment disorder with depressed mood, which is like a response to a stressor. That's what adjustment disorder is. It's fairly short-natured and is not a severe diagnosis. Or unspecified depressive disorder, which is a less severe diagnosis than major depression. Either of those two would be fine. It's within the ballpark. What is not okay would be picking schizophrenia. Schizophrenia is a totally different thing, right? That involves hallucinations, delusions. It doesn't fit the symptoms. So that's the thing to be aware of as you're going through this and make your diagnosis. Make sure it fits the symptom profile. Let's talk about case conceptualization briefly. One of the other things you'll learn in this course is how to think about clients, how to not only diagnose them, but how that diagnosis fits within your overall understanding of them. Case conceptualization refers to a lot of things, includes your theoretical approach, for example. What we'll work on in this course is you identifying the presenting problem, the symptoms they have, the social and cultural influences of those symptoms, the provisional diagnosis that you would make based on that, based on all that information, and then some initial thoughts about treatment plan. We'll talk about treatment planning in just a moment. I'm interested in what kinds of initial goals would you suggest, recommend to the client, and what subsequent goals would you recommend after the initial period is ended, meaning that they are stable, for example, or they've worked through what they needed to work through initially, and they're ready to work on like maybe another goal that's important to get to, but not at first. Now, what you should know about treatment planning, just as with diagnosis, it's not perfect. It's an imperfect fit for mental health. A classic example, this is the dental filling to cavity example being a great fit compared to our diagnosis for mental health disorders. So if you go to a dentist and you have a cavity, then they diagnose the cavity and they give you a filling, and the treatment very clearly taps into the filling, taps into the cavity, taps into the problem that they're presenting with, okay? However, with mental health, it doesn't quite fit that way because we are looking at a holistic person. So a person may present with depressed mood, for example, but it's not like you can create a very specific treatment just for depressed mood. There's all different aspects of the person you have to look at: their social cultural background, their life situation, who they're living with, their job, their preferences, their attitudes, beliefs. All those things matter a lot in mental health. And because, even though you might think that depressed mood is a fairly discrete thing like a cavity is, it's really not, because depressed mood can be caused by all aspects of a person's life or could affect all aspects of their life. And so treatment planning isn't a perfect process for counselors, because you have to basically boil down a holistic process where you're looking at all different aspects of a person into something very tangible, something very specific action that you're doing in counseling, which can be a challenge. right? Instead of just listing why, I would, form a relationship, which could take a while, and who knows what that will require. You can't really write that in a treatment plan, so you have to be more specific, but it's not a perfect fit. So you need to directly address in a treatment plan for insurance companies, for other providers, to understand what you're doing. Address what the primary diagnosis is, the first one that you're going to address, okay? And then outline the expected outcomes of treatment. The reason that you address the first diagnosis is that that's how insurance companies will understand it. They're like, well, okay, you've made this the primary diagnosis, the first thing. So it makes sense that you're doing this first, right? First things come first. You describe the actions to be taken in your treatment plan, what you do, what kinds of interventions you use, includes referrals to other professionals, in addition to things like, your basic techniques you're using, whether or not it's, some coping skills or cognitive restructuring or empty chair technique or, et cetera, et cetera. Most goals, as I mentioned before, will be collaboratively determined by the counselor and the client. These aren't things you should just determine by yourself. And try to privilege the client's self-direction when you're doing this, okay? Because it's important for the client to have some degree of input into what they want to work on in counseling and in what order they want to work on it. We're at summary. So we've talked about the use of person-first language and how important that is when thinking about people with mental disorders and how to work with them. Being kind to yourself and recognizing areas for growth as you go through this material. Realizing that diagnoses exist within a context and you shouldn't boil down a person just to their diagnostic label. Considering that many clients will present with specific symptoms, and it's helpful to work at the symptom level and the movement based on the research domain criteria towards idiographic assessment and my approach to this course and training you in that. We've also talked about the importance of distress and severity when making a mental health diagnosis. We talked about 3 important terms when also creating a diagnosis: reason for visit or primary diagnosis, provisional, and rule out. We talked about making a differential diagnosis with things like rule out and considering cross-cutting symptoms and how it can be a challenge to make a mental health diagnosis. And then lastly, that diagnosis is an imperfect art and we don't have biomarkers. And so being in the ballpark is important, but being exactly precise, and everyone agreeing on the diagnosis, maybe not, as long as we're in the ballpark. That wraps up this video lecture.